If you had one thing that you want to tell people about Ebola, let's say you had the opportunity to give a message to just the general public, what would that message be?
Yeah, thank you so much. Maybe if I had an opportunity, and more so in our setting there, the crowded setting, the low education, and other things, the message would be simple things like hand washing. Simple things like actually identifying, like for example, any patient you find that you are suspicious and then you think that there's something which is unusual, like minimize contact, hand washing, isolating the patient, and then seeking help. I think, because I think that in all our countries, at least this one, we don't need any resource at least to do it, to achieve. All of us can achieve this. And if we did this, actually, because I have a feeling that things like that, actually, hand washing, it won't only prevent like Ebola and the other diseases, but there are also a spectrum of other health conditions that you will have prevented. So if I had a chance, and it would be the people to emphasize those simple things to do it, and educating the masses.
One of the big problems with any outbreak of Ebola has been the fear involved and the psychological effects. What psychological effects did you see in Uganda, and how were they dealt with?
So from the ministry lab, if the sample could come out and it's negative, so what we could do is that we could counsel the patients. Then we counsel them about, of course, because we know that if someone came and told you that you have Ebola, it's like a death sentence. Because actually most of the people start planning for their death because they know that chances of survival are very minimal. So at the end of the day, we counsel them. And though the only problem that we have as a setting is that, in our setting, is that we do not have counselors, professional counselors in our health system. Much as there are people who have done counseling as a course, but in our health structure, like in any hospital or any health facility, it's very hard to find someone who has been employed as a counselor. So most of like the health workers who are going to give some counseling skills are those who went and then they got some orientation. Like for example, in HIV management, they put some, there is some component of counseling. So at the end of the day, like we use some of those people who have been having some of that orientation, and then they could attend to these patients. So they attend to the patients, they counsel them and they encourage them. Then after encouraging them, then they go to the community where the patient comes from. They meet with the community leaders, they meet with the relatives of the patient, also counsel them before the patient actually is discharged. So, and then they request the other people to allow this patient back into the community. Then, so what happens is that then after all that system, we have gone through that system, then we give the patient a certificate that they have been discharged and they are very okay and they can be allowed to go back into the community. So when this patient is discharged, actually, we are the ones who could take the patients back. So like we could use our ambulance, take the patient back, then we hand over the patient and tell the communities that he or she is okay, you can accept them, and then they live with you. But it's very challenging because, like, for example, one of my colleagues was a health worker who contracted Ebola in one of the other epidemics which were in the country, in Chibale. For her, she did what? After surviving the epidemic, she was discharged. So she went home, and then one day she went and visited, like after some time she went and visited her in-laws. And when they saw her, everyone ran away. So everyone was looking at her like they had seen a ghost. Everyone, the moment they could see her, they could run away. But counseling is key, though. We try and we counsel them, though at the end of the day we might not do much, but at least we try. The little that we can, at least we try. Like for example, like one of those ladies actually, she got amenorrheic for like since admission, like in the facility, ever since that time. Actually, up to, I think, like over a year, she could not get her periods. And she could not get her periods. Then she could get also other unclear symptoms, like for example, like, you know, like those things you can get, like a headache, and then you get this, such things. So at the end of the day, not very clear, like these are very clear for Ebola, because actually every patient that has gone through this illness or what, they narrate it differently. But most of them actually, the biggest problem is psychological torture. And then, because some of them, if they are ladies, their husbands, of course, will run away. They will never come back. Because there are some who think that you cannot have Ebola and it is cleared from your body. So they are like, to be safe, no. So the marriage has to end. So Ebola separates them. So those are some of the major challenges that we do. But at least we try to cancel them. And those are the avenues that have been put in place to do it, to try to see that these patients are accepted back into the community. And when they go into the community, they do what? They can also be helped. Though we don't have other structures which can give some rehabilitation. Because, like, for example, actually, like Gloria, I know Gloria will be visiting the US one of these days, actually, to do it. Most of the time, actually, when she's even narrating her story, she breaks down. Actually, most of the time, when you tell her to tell us what she went through, she breaks down and cries because of what she remembers. Because at the end of the day, she's this young health worker. She's a midwife. She was working, doing government, whatever work. And then at the end of the day, she contracts the virus. And she has gone through a lot. And ever since, and after going through all a lot, no one seems to care. And that's the biggest problem. No one seems to care. You are good when you are alive. The moment you get these problems, now everyone is distanced from you. If you're lucky, you will continue getting salary. But at the end of the day, what they can is to transfer another person to your place. But no one seems to care. So she went through a lot. She was there, and then you are admitted with a colleague you are working with at the same facility. Then you watch your colleague die. And you know that what has killed your colleague is what I also have, and then she survives. So at the end of the day, every time actually she's sharing her story, she breaks down and cries because of what she has gone through. And actually, even right now, you really see that she needs rehabilitation, but there's nothing much because we don't have that in our structure. But we just do the basic elementary counseling and what. That's all that we can do for our patients. And the other thing is that we don't even follow up. Now, like, for example, the statistics that I showed you, the number of people who have survived through. But one of the cultures that we do not have that culture of following up our patients. Because the moment you are discharged, no one cares to know what happens to these people. Maybe 6 months later, 1 year later, no one cares to know about that. Yet I would think that this would be a very good area for research in our setting, but no one cares about that. Actually, I was recently shocked because one of the TV stations in our setting tried to follow up on the survivors of the 2000 epidemic, and they had a very nice documentary. And these people are giving the experiences and how they have coped with life ever since the epidemic. But actually, when I was watching it at home with my wife, I was telling her that sincerely we have to wait for the journalists to come and do our work. Because the journalists, I think, waited for the health workers to go and do the follow-up, and no one seemed to be interested. So what they did for them, they went and they got their documentary, and at the end of the day, everyone was very willing to stand for them, actually, so long as they can get an audience. So that is one of the unfortunate bits that we have.
Since the 2012 epidemic, when you get patients in your clinic now, have you changed the way your approach in looking at their diagnosis when they come in with any symptoms?
Now, one thing is that for the scholars, they tell us that change is a very long process. And one of the biggest challenges that we have is the health worker attitudes, because very many health workers actually do not want to Like they resist actually change, because most of the time the things which help us as health workers, in most cases, you have to pay some price in a way. Because like, for example, like I said, like the history taking, it's going to do what? Like it means you'll spend much more time with the patient. So, but a number of things have changed, because like, for example, for me, where I come from is that now we had to put in place like drugs for emergency, and also we had to put up a corner where we keep some stuff in case like maybe we are confronted with, we don't wait now like for calamity to strike. At least now we put up some protective gear and we kept it somewhere, and then we are like, in case it happens again, then maybe we shall have a starting point. That is number one. Number two, we put hand washing facilities. Now at least it is a must, because at that time it was whoever wanted to do. But now at least everyone, they know the importance and the usefulness of doing what? Of washing their hands. And so we put hand washing facilities actually everywhere. Because initially we had like 2 hand washing facilities in the whole facility. But now every department has their hand washing facility. And we ensure that someone puts water in the morning and then they put a piece of soap, which is a plus. Then the other thing is even record keeping, because we are trying to do what? To ensure that records are kept very well. Though that one, in most cases, it depends on who is heading a unit, because there are some, records are very tricky. You can keep records, and at the end of the day, they show how unserious you are. So in such a case, some people prefer that the records are far away from them, because they might expose them. So that is the. But at least, a number of, I think, facilities have embraced that. And actually, where I'm doing my residency program right now is that actually there is one of my supervisors. Actually, he's trying to do something, and he's reviewing records to see whether the data which we as clinicians record, some other person like who is going to review this file 5 years later can make something out of it, whether there are no gaps, whether everything was done correctly. And so if we have reached there, I think that maybe something is going on. Then the other thing is that these days now health education and CM is in all facilities. It's mandatory. They're supposed to be there, actually. And at least in a month, we are supposed to have at least 1 or 2 CMEs. And because we think that by refreshing this, like health workers remind themselves on what is on what they're supposed to do. And ever since those epidemics, even government commitment actually has improved, because the drug stockouts, they are not as frequent as they used to be that side, because that time actually. Because now these days, at least you go to a facility and the patient can comfortably enter, and then they get for most of the communicable diseases, they can get now the problem is the non-communicable diseases. But most of these communicable diseases, most of the time the medications are there, and they have tried their best. Actually, there are partners who have come on board also, and like for example, the district where I come from, we have partners who have built for us laboratories to help to up our investigative power. And so at the end of the day, a number of things have changed. Like I said, some of these epidemics have been a learning experience for us. And the other thing is that not only the epidemics in Uganda, when our government saw what happened in Western Uganda, nowadays their commitment towards health has sort of improved, because at the end of the day, at least now, things are being taken much more serious, and which is, I think, a plus. So at the end of the day, I think today, if you came to my facility, if a patient came to my facility and they found me there, and they came and then maybe with a dangerous pathogen, infection, I have a feeling that it might be much simpler for me to pick it compared to how I was before 2012, because of the exposure and the orientation that that we have got. Because even when after getting these epidemics, like very many stakeholders came on board. Like WHO came and they did a lot of teachings. Now the USAMRIID also comes. Now they are also helping us to do what? To do a lot of some work. So at the end of the day, I think like if someone has a good attitude and they are willing to learn, I think now at least patient management and diagnosis, I think, is much better compared to how it was before.
So, Dr. Innocent, you had mentioned several times the importance of good record keeping in terms of identifying disease outbreaks. I was wondering if you could perhaps elaborate on those pieces of information that in particular can be helpful in identifying the outbreaks. And I'm thinking in terms of for the teaching that USAMRIID does with Infectious Disease Institute along the lines of that VOTE, an acronym.
Wow. Thank you so much. Now for record keeping, personally, because now you see I'm crossing from infectious diseases. I'm going into maternal and child health, but in Uganda, of course, there is no big line because we are not super specialized. Because you cannot say I'm a gynecologist and I only see gyne cases. Because you'll be a gynecologist, but still one day you have to do an operation for intestinal obstruction because you might be the only doctor around. You might be a gynecologist and you have to treat an HIV case because you are the only physician around. So at the end of the day, we do not have a clear line between our specialties. Though in Uganda, if you specialize, it means that most of the work you will do will be obstetrics, but you will also do other things. So specialization, it will just, I will tell you that you will do most of this, but you will also, it doesn't mean that you want to be doing other things. Because I was told that here, if you are for the nose and you touch the eye, you can be sued. But for us, no. Actually, for us, people will be happy to have a doctor to touch them. So history, the elements of history, of course, it begins with the identification, because you find, like in a typical case, in a typical clinic in some of our developing countries where the patient load is too much, there is what they call a next syndrome, where a doctor sits and they have a line of 50 patients they are going to see in 4 hours. So you come and you write your name, then asks your complaint, and before you finish your complaint, he has already written the treatment. So before you even say that, I also have this one, he's calling the next patient. He's calling so at times we call it the next syndrome, because next, because someone wants to beat the line and they have to go and do other things because of the very many patients that we have. So, but it begins with the identification, at least getting the patient's identity, where they are coming from. Because at the end of the day, it can help us to localize some of these illnesses from which geographical areas they are coming from. Because you can find, like, for example, if I look at, like, for example, cholera and other very infectious diseases, you find that some of them actually, you can find that a community which has maybe poor waste disposal, maybe no water, and then they have a particular illness. So it can help you in identifying, because if I'm seated in a clinic and I get three people who have diarrhea and they're coming from the same parish, it will mean that it will ring something, and it will be different if I have 3 diarrhea cases and they're coming from different areas. But so identification is very, very important and it's very key. And there, of course, have to take all the name, age, sex, where they're coming from. Actually, for us, we even take the distance from the facility, then the next of kin and all the other things. Then the complaints of the patients, and then the history of how these things have been coming, how they have evolved, how have you been, like, you have had the fever, how long has it been? What is the pattern of the fever? Have you taken any medication? Is there anyone in your setting who has been having anything like that? So at the end of the day, like, the history is supposed to help you to try to see if there are any relationships which you can build, like, to make you to come to a particular diagnosis. And it's also supposed to help you to rule out some other illnesses. Like, for example, if someone, like, for example, in this case, she comes, they have fever, they have chest pains, and they have general body weakness. So, and in our setting, HIV is very common, TB is very common. So we have to rule out that maybe these might be symptoms related to TB. So that's why we have to talk about the night sweats, evening fevers, and all those things. So, and then we were like, maybe, so at the end of the day, my child had chest symptoms. I did not do sputum analysis. The reason was that from my history, I thought that that patient did not have tuberculosis because I ruled out. So history is supposed to help you to go on doing what? Building, and then such that, like, by the time you reach the investigations and examination, you can zero down to a particular system and then to particular investigations, such that you don't just do. And then, and in our setting, like, you have to, because now, like, we rely more, because over 80% of our diagnoses are based on history. And because even you cannot send all those patients to the laboratory if you are in Uganda. So at the end of the day, what happens is that your history is supposed to be very good, such that it helps you to do what? To pick out a diagnosis which you are going to treat, and your patient doesn't come back tomorrow. Because the other embarrassing thing is to treat a patient and then they come back and you treated them yesterday and they go to us. Then, so at the end of the day, the history is supposed to get that. Then also important information which can come, like in social history and like for example, where they come from, the family setting, how is it organized, how do they do their things at home, is there anyone who has a similar illness like that? Because it was at that point that we picked our outbreak, because we realized that much as these symptoms were malaria-like and we were in a malaria endemic zone, and November, because we have 2 seasons for malaria, because for us malaria comes during the rainy season. We have the March-May season, and then we have the November-December season. So it was December season, and the blood slide for malaria parasite was 3 positive, but at the end of the day, we did not concentrate on the malaria reason, because when we took that history, we realized that it cannot be. It is very, very hard for 3 people to get the same malaria symptoms and then the same complications at the same time, really. Maybe if they are bitten by the same mosquito, which I doubt. But now that was a joke. No, but at least to establish associations, and at the end of the day, they help you in diagnosis. And 1 minute more you spend on a patient when you're interacting with them, when you're taking their history, can help you do much more, actually, in getting a right diagnosis. When I was in medical school, one of my classmates went and didn't take a good history for a patient, and the patient had the septicemia, secondary to septic arthritis. So this patient, like for us in our medical exams, they cover the patient and they want you to take the history, you examine, and you come up with a diagnosis. So this patient, this colleague of mine takes the temperature first. I don't know why. And the temperature was 39 point something, very high. So, and the patient was very sick. So he tried to hold the patient's neck, and the patient's neck it seemed stiff. I don't know. It seemed stiff. So what he did was like, this patient must be having meningitis. So what he did was he grabbed the patient's leg, which was sick, and the patient winked in pain. Then he said, Cunning's positive. So when the examiner comes and then tells him to present, so he presents. They say, Cunning's positive, temperature this, what's your impression? It is meningitis. What are you going to do? Lumbar puncture. They say, hey, sure, yes, lumbar puncture. What are you interested in? This and this. Then he told him, expose the patient. Then when he exposed the patient, he found septic arthritis, and that was the end of the exam. So history taking is important. If you just don't take the history well and you examine your patients properly, you can end up treating meningitis when the patient's problem is septic arthritis, and you don't help them.
As a follow-up then to that question, sounds like, as you mentioned before, that getting those key pieces of information can certainly assist with that diagnosis, and things such as vaccination history, their occupation, perhaps where they work, the travel. You mentioned before that if Uganda being a very porous nation, that you could have patients from DRC or Kenya or other areas that come into the country quite easily, as well as even exposure history. That sounds like those are those key points that could certainly be critical in identifying an outbreak, particularly in the early phases.
Thank you so much for that. Maybe the other thing which I didn't comment about was like the previous outbreak we had in the district. We were suspecting that it might have come from bats, and then maybe a bat which was infected pecked a fruit, and someone ate a fruit, and then it got into the population. Now, for us in our setting, they actually, like I said, we have very many bats. That's why actually I was showing you the other side. But even so, in our health education, actually, those are some of the things we have to talk about. Like, don't just eat any fruit which maybe it was pecked by something you don't know. Even if actually you know that it was pecked by a bird, don't eat. And then we also have actually, for us, those of you who have been to Uganda, like in our buses and what, we have stopovers where people eat muchomo. Muchomo is it's like barbecue, but for it is too local. They just put meat on a stick and put it in fire. So you find people like, hey, anyone buying? So you just point and then they give you. So, and most of the times this meat is uncooked, and at times you don't know where it is coming from. Actually, I was told that in DRC, in Eastern DRC, that monkey meat is very delicious. That's what they say. And it will be very hard for you to just come and tell them not to eat their monkey meat. Maybe some will say that maybe you rather tell them how to prepare it better, such that it is ready. Because if you just come and say, don't eat the monkey meat, they will just look at you and they say, this person doesn't know what they're talking about. So, and if someone is vending their meat on the roads of Uganda, you don't know where they got the meat from and what you are eating, because it might be bush meat, because these people are trying to survive. So if they found an animal in the bushes and then they hunted it and then they put it there, it would mean they would be getting 100% profit. So at the end of the day, those are some of the things that we actually, even in the history we pick them, but also in the health education we emphasize that people, at least, they minimize travel, and when they're traveling, they should desist from doing some of those things.
So I know I'm the question man for today, but actually also wanted to ask, prior to this outbreak, and perhaps going back to your training as a medical student, can you elaborate on perhaps what you were taught about Ebola during your medical education, and maybe some things that perhaps might have been helpful at that time?
Yeah, thank you. I was in medical school in 2002 to 2007. That was for my bachelor's in medicine and surgery in Mbarara University. So while I was in Mbarara University, of course they have we train on some of these. We are trained on how to manage some of these diseases and epidemics. But I should say that for me as an individual, outbreak management and identification, most of the exposure, I got it when I was doing my master's in public health, because at least there was actually a topic which was like managing an outbreak. And this came actually before actually, it was around the same time when the epidemic actually did well, because I finished I graduated in 2012. So at the end of the day, I think the exposure, most of the exposure was during my public health classes, because most of the times when we are, for us in our undergraduate trainings, most of the times if you're doing medicine, they'll treat the patient. You read Ebola definition, epidemiology, clinical features, management, investigations, and something like that. So in most cases, you may not go beyond that. Like, for example, that if this is Ebola, you're supposed to form this, and you're supposed to, surveillance is very important. In most cases, for our training in medicine, they look at the case which is going to present to you. How are you going to identify that it is this, and how are you going to manage it? So this other aspect of community and the prevention bit at the wider scale, most of the time you may need another orientation or another training in it. So though these days I understand that some stakeholders who are trying to help and incorporate some of those trainings in some medical schools, where they go to medical schools and then they help them to do what? To teach them. But the other thing is that if you have been, if like you're doing public health and or any other master's program in our setting, and you have had prior exposure, some of these things make a lot of sense. Because if someone is just new in the medical school and they're teaching them how to manage an outbreak, it might be a little abstract compared to some other person who has had prior exposure, has seen patients, knows the communicable diseases, then and all other things, and then they do it. But yes, in undergraduate, I was taught Ebola and how it does and how to manage the Ebola. But outbreak investigation and management, most of the exposure was when I was doing my master's in public health. Yep. Though still when I was doing my master's in public health, I was so much into maternal and child health because that was my interest. And so I'm so much into the mothers and children compared to the rest. Thank you.